I'm Dr. Amna Ehsan, Professor of Obstetrics and Gynecology at Lahore General Hospital. It is a pleasure to welcome you all to this session of IRC focused on gynecological cancer, a topic that holds a significant importance in the women's health. We will delve into latest advancement in the diagnosis and management and patient care in this critical area of gynecology. We have plenty in store, so without further delay, let's proceed. First of all, we are going to welcome our esteemed panelists of experts on stage. All of our panelists are extremely gifted and accomplished individuals with years of experience in the field of gynae. We are really grateful they have spared time from their busy schedule to educate our audience with their knowledge and experience. Let's welcome. Our first panelist is our dynamic, visionary Professor Dr. Fareed Zafar. He is a living legend in the field of gynae and ops with years of clinical experience and deep commitment to patient care. He is principal of PGMI. He is president of Society of Gynae Oncology. Our next panelist is brilliant and vibrant Dr. General Sheila Bakai. She is a Dean and Principal, Bahria University of Health Sciences, Dean Faculty of Obstetrics and Gynecology, CPSP. Professor Roshan Arakazi, she is a brilliant and renowned gynecologist and Professor of Ops and Gynae in Liaquat Medical University, Hyderabad. Dr. Sadakat Jabin, a knowledgeable ex-HOD of Lady Reading Hospital, Peshawar. Madam, please come to stage and have a seat, please. The bright and brilliant Dr. Nabia Tariq, HOD Maroof International Hospital, Islamabad. Dr. Alia Aziz, a talented and competent associate professor in Agha University, Karachi. Thank you very much, my dear panelists, for sparing time from your busy schedule. Now we are honored to present a distinguished panel of experts for poster presentation, whose collective experience span clinical practice, research, and education. Each expert brings a wealth of knowledge and insight into latest advancement in the diagnosis and management of gynecological cancer. Our panel of experts comprise Brigadier Ambreen Anwar, Dr. Firdaus Mumtaz, Brigadier Humaira Tabassum, Dr. Naila Ehsan, Dr. Shabnam Tariq, Dr. Shehzadi Saima, and Dr. Zahida Parveen. The poster experts panel is requested to proceed to the respective venue right now. And all the poster presenters, you please go to your, in front of your poster before the arrival of panel experts. Please request all poster presenters. There will be a cash prize for first, second, and third best young researcher. There will be a certification for oral and poster presentation that will be awarded tomorrow. Before we begin, I would like to outline the rules for presenters. All presentations should be finished within 10 minutes. A buzzer will sound at 8 minutes as a soft reminder, followed by slides down at 10 minutes. May I kindly request everyone to put their mobile phone on silent mode to avoid any interruption. I would like to invite my first speaker. She is Dr. Noreen Zafar. She's a renowned gynecologist and obstetrician at Doctors Hospital. As we are honored to have her here as speaker today, the title of her talk is Cervical Cancer Elimination, Our Reality. Dr. Noreen, please come to stage and join us for your talk.
Thank you so much for allowing me the privilege to talk today. And I'm sorry I've had to change the sequence because my son's best friend's wife is in labor. Although I'm not at all a busy obstetrician, but nevertheless, I had to leave today. So thank you very much, Amna and Shima and everyone for letting me go first. So this is something that is really, really close to my heart, and I wanted to share this with you that today, cervical cancer elimination stands as a reality. We'll just talk about how cervical cancer is and how it is affecting the lives of women around us. Globally, you all know, you've all heard that 600,000 cases of cervical cancer are reported almost every year. That's to 2022. More than half of these women will die, and more than 85% of them live in poor countries like Pakistan. Whereas in the developed world, screening programs and now HPV vaccination has literally changed the game. So this was a slide that I was taught when I was at the RCOG for my training, that the screening had really reduced the incidence of cervical cancer significantly. And this is a slide that we got presented with a couple of months ago, Kate Kusheri's group from Scotland, who have actually shown that there's a 0 incidence of invasive cervical cancer amongst the cohort of Scottish girls who had been vaccinated at the age of 12 and 13 years. So there is no doubt that cervical cancer is a preventable disease. No woman should die of it. And even if cancer develops, it can be picked up early and it can be treated entirely, completely. So in 2019, WHO started this global strategy to accelerate the elimination of cervical cancer, and they presented what we call as 90-70-90. 90% means 90% of the girls in the teenage group should be vaccinated. All women should have a couple of screens at 35 and 45 years at least. 70% of them and 90% women with invasive or pre-invasive disease should be treated. So what makes cervical cancer a standalone cancer? It is the one cancer that we can surely say is caused by human papillomavirus, largely most of the cases. We know that there's a vaccine for this virus. We know it is a slow-growing cancer by and large. It can take 10 to 15 years to start from an abnormality, which is almost always reversible, easily treatable, to developing cancer. So theoretically, there should be no more cervical cancer, and I think this is exactly what is happening in the world that we just discussed. But unfortunately, Pakistan still is one of the top 7 countries where the incidence of cervical cancer is at the highest. One single year, 2022, there were over 5,000 cases of cervical cancer. And this, please remember, is the tip of the iceberg because this is what was reported. And out of them, 3,400 women died. So that is roughly 14 women dying of a preventable disease every single day in Pakistan. So that means that every month, literally a Boeing 777 full of women is dying of a disease which is number 1, preventable, number 2, completely curable. And this, I think, is the greatest tragedy of this century, that cervical cancer, in spite of being preventable, is still killing so many of our young mothers. And please remember that cervical cancer is responsible for 1/4 cancer orphans across the world. But there's a huge window of opportunity where screening comes in. So from what we are able to see on the left-hand side till we move on to the right-hand side, there's roughly a window of around 10 to 15 years when, if we are able to examine the woman, we should be able to pick up the precancerous changes and therefore treat her completely so that she doesn't have to die of this miserable disease. But actually, our situation in Pakistan is getting from bad to worse. We hardly manage to screen 1 to 2% of our population, and that usually is in the context of a research study that we are doing. Then we don't have an HPV vaccination program, but hopefully in the autumn of 2025, the vaccination should arrive as a part of the expanded program of immunization, and we are looking forward to that. But also changing social norms, changing reproductive behaviors, global traveling, and a lot of our younger generation is smoking now. So these are all risk factors which are going to even increase the incidence of new cases in our country. Now, what are the difficulties in talking about cervical cancer? The biggest issue is really the prioritization of women's health, where we put the women's health in our agenda, be it a national agenda, a provincial agenda, or an agenda of a family who are not earning so well. And then secondly, because of the sexually transmitted transmission, there's a significant taboo in talking about cervical cancer. There's a stigma in talking about reproductive health anyway, be it reproductive issues like periods or dyspareunia or infertility, but also the cervical cancer, and the gender lens and inequity that we face, along with the poverty of resources that our country faces. I think it is time for us people who are empowered and in a position to help the women to take charge. And let us make this vaccine opportunity a success, because this is the biggest worry at the moment, that there's only 6 or 7 months left for the vaccine, but we are very, very poorly prepared for advocacy for vaccine. And now we are going for a single dose of Sicolin, so it is a very, very easy, straightforward vaccination that we should be able to provide our young girls with to protect them from cervical cancer, developing of cervical cancer, along with screening. So after vaccination, primary health promotion, a good hemoglobin level, good immunity, good reproductive services, family planning, all these are important issues that will help us women to stay safe of developing cervical cancer. And then this is what we have been using in many of our studies, and also still continuing to use as a normal cervix. That's a cervix after application of the acetic acid. The proteins are higher in amount in a pre-cancer lesion, so they will come and identify themselves as white, and we can treat it with cryo. We also do pap smears. Many friends are sitting here who do that regularly, but the WHO recommends HPV testing, which is a single test, which is cost-effective and much more reliable. Further to that, we need to centralize our referral services, because we need to develop and identify colposcopy centers, and we also need to improve our treatment and palliation and quality of life amongst the survivors. So beyond our clinics, what we can do, this is a picture of the situation analysis that WHO, we just did it for WHO for breast and cervical cancer. This is advocacy meeting with the First Lady. This is talking to women in corporate offices, schools, colleges, talking to the younger people. And every year we run a platform for cervical cancer campaign, and we would welcome all of you to join this. I very humbly request all of you who are present here, you're all influential people, you have effective skills which can be helped. Please join us in changing this narrative, and let cervical cancer be the first cancer that is eliminated from this world. And finally, this is what Margaret Mead said, but it is very close to my heart, that never doubt that a small group of committed, thoughtful citizens can change the world. Indeed, it is the only thing that ever has. Thank you very much for your listening.
Our next panelist is our young speaker, Dr. Mishal. The topic of her presentation is risk of malignancy index plus international ovarian tumor analysis versus risk of malignancy index alone in assessment of malignancy risk for adnexal masses undergoing gynecological surgery. Dr. Mishal is a postgraduate FCPS trainee at Federal Government Polyclinic Hospital, Islamabad. I will request Dr. Mishal, please come to stage and deliver your talk.
Assalamu alaikum and good afternoon, ladies and gentlemen. You can be a victim of cancer or a survivor of cancer. It's a mindset. Thank you for the introduction, madam. My name is Dr. Mishal Maqbool. I'm a postgraduate trainee of OBGYN at Federal Government Polyclinic Hospital. And my study is RMI plus IOTA versus RMI alone in assessment of malignancy risk for adnexal masses undergoing gynecological surgery. These are the table of contents. Now, before we begin, just a general overview of what's RMI and IOTA. RMI is a scoring system which is used to assess the likelihood of malignancy in ovarian tumors. It consists of a calculation formula that uses CA-125, ultrasound score, and menopausal status. Whereas IOTA, or International Ovarian Tumor Analysis, is an advanced method for assessing ovarian tumors, which is aimed to distinguish between benign and malignant tumors. It utilizes imaging techniques, including ultrasound, which consist of B-rules and M-rules. Adnexal mass that originate from pelvic organ, they vary with age and often necessitate surgery, with 80% of them being benign. Ovarian cancer, however, poses a significant global threat, showing diverse mortality rates among ethnic groups. Late ovarian cancer detection results in a low 46% 5-year survival rate. And accurate differentiation between benign and malignant tumors is crucial, and tools like pelvic ultrasonography, RMI, and IOTA assist in this. However, IOTA, it may yield conflicting results, and CA-125, it has its own limitation. The objective of my study is to compare the diagnostic performance of RMI and IOTA in combination with RMI alone in assessing the risk of malignancy in adnexal masses. This was a prospective cohort study conducted at PIMS for 6 months from March till August. A sample size of 49 was calculated, and all the women which presented with adnexal mass greater than 5 centimeters and they were planned for surgical removal or biopsy, they were included. However, pregnant women or those receiving expectant care, ones with non-measurable serum CA-125 levels, with non-estimated IOTA or RMI, and the ones with insufficient follow-up, they were excluded. The women were included in the trial after approval from the ethical committee. Age, menopausal status, and serum CA-125 levels, they were extracted for each patient, and a transvaginal or a transabdominal ultrasound was performed on the subject. The information was then divided into 2 groups, RMI and IOTA, and depending on the size of the tumor, the patients, they either had a laparoscopy or a laparotomy, and all the patients' tumor, they underwent a histopathological investigation to determine if the tumor was really malignant or benign. And out of the 49 patients, 35 patients had benign, 1 had borderline, and 13 had malignant diseases. There were 20 postmenopausal and 29 premenopausal women. Age and disease status, it did not correlate significantly. And the mean and the median of CA-125 levels for the patient with benign and benign diseases were 30 and 24, and for the subjects with malignant disease were 350 and 280 respectively. The same can be seen from this table. According to the RMI, 14 of the 49 patients who participated in the study had malignancy, and 35 were benign. Whereas as per IOTA, 5 of the 49 women had malignancy, 25 were benign, and 19 were inconclusive tumors, a big chunk. As a result of this, what I deduced was that RMI outperformed individual criteria, that is ultrasound, CA-125 levels, and menopausal status in distinguishing benign and malignant tumors. The RMI, it reduces the bias that results from the subjectivity of the examiner, and compared to other studies, the RMI study in RMI sensitivity in our study was found to be less sensitive. In a recent study by Van Kalster, the IOTA actually was found to be more accurate for triage than RMI. But contrary to that study, our study demonstrates that RMI is more accurate than IOTA. The reason being that IOTA displayed an unusually high rate of equivocal results in our group. As a result of that, 38% of the women, they would have been inappropriately referred to gynecological oncological center since their tumor was deemed ambiguous. So this cohort study, it showed that RMI is a relatively useful diagnostic model in characterizing ovarian tumors, whereas the IOTA, it only performs fairly. The strength of my study was that it's a clinically significant study which compares the RMI and IOTA. It's a prospective cohort study, and it uses real-time data, and it minimizes bias. And clear sensitivity and specificity results, they enhance clinical applicability. But like every other study, my study also had certain weaknesses. Them being, it limits the generalization of the findings, and a high rate of inconclusive cases under IOTA, it reduces its diagnostic utility. And the operator bias in interpreting ultrasound and IOTA feature, they may result in consistency. As a result, I conclude that RMI is a rating system for adnexal masses that uses open tests. Despite its limitation, RMI demonstrated higher accuracy than IOTA in clinical practice. Both diagnostic tests, they don't seem discriminative enough because of RMI's comparatively poor sensitivity and the significant rate of ambiguous results of IOTA. As a result, other diagnostic models are required. The recommendations from this study are to utilize RMI as the primary diagnostic tool for adnexal masses, given its higher accuracy compared to IOTA. It's to refine and standardize IOTA criteria, to reduce the rate of inconclusive results, and to conduct larger, multi-center studies to validate findings and improve diagnostic models. These were the references that were used in the study. I will end this by saying, September ends, so will ovarian cancer. Someday, until then, we hope. Teal is the official color of ovarian cancer, and September is the awareness month for ovarian cancer. Thank you so much for your time.
My next speaker is Professor Dr. Khayal Azam Khalil. He is Fellow of Gynae Oncology at Shaukat Khana Memorial Cancer Hospital, Lahore. He will be talking about laparoscopic versus open surgery for advanced stage ovarian cancer, a 10-year data analysis. Dr. Khayal, please join us on stage.
I'm working as a fellow in gynecology oncology at Shaukat Khana Hospital. I will be talking about laparoscopic versus open surgery for advanced stage ovarian cancer. This is a 10-year data analysis. I don't have any conflicts of interest to declare. Minimally invasive surgery has been there for a while. It's been incorporated in a vast majority of surgeries. That includes gynecological oncology. Laparoscopic surgical technique has proven over time to have superior postoperative outcomes compared to open surgery, including but not limited to recovery time, postoperative pain, and blood loss, to name a few. The treatment for advanced stage ovarian cancer includes neoadjuvant, which means before surgery, or adjuvant chemotherapy and debulking surgery. Laparoscopic surgical technique has been applied to oncological surgeries for several years with good outcomes. Laparoscopic technique is usually the most requested by patients as well, and reduced hospital stay and decreased pain management offsets any initial cost considerations. So the question is that when there are obvious advantages of laparoscopic surgery, why would we go back in time and compare laparoscopic with open surgical technique to look at oncological outcomes? This question arose because advanced stage ovarian cancer is like peritoneal disease, so it can be anywhere and everywhere. Achieving R0 resection, which is complete gross resection, which means that leaving behind less than 2 millimeters of tumor, has proven survival benefit in ovarian cancer. The other consideration is that there is a landmark trial called LAG trial, which compared minimally invasive and abdominal radical hysterectomy in cervical cancer. And the conclusion of this trial was that minimally invasive surgery had inferior survival outcomes compared, including overall and progression-free survival compared to abdominal surgery. So that made a lot of gynecological oncologists cautious about the surgical technique. So the objective of our study was to compare surgical outcomes, progression-free and overall survival in patients with laparoscopic versus open surgery for advanced stage ovarian cancer. This is a retrospective cross-sectional study which was conducted, from January 2014 to January 2024 at the Department of Surgical Oncology at Shaukat Khana Hospital in Lahore. 171 patients were found to fulfill the inclusion criteria, which were women with stage 3 and 4 ovarian cancer who underwent surgery. Exclusion criteria was early stage ovarian disease, so stage 1 and stage 2 disease, morbid obesity, BMI more than 40, ECOG performance status, which is the baseline functional status of patients, which was more than 3, so these patients were sick at presentation. These were excluded from the study. Women who did not undergo surgery were also excluded for obvious reasons. Patients with more than one primary cancer that had an impact on their overall survival, these were all excluded. Surgery for recurrent and residual disease, which is usually technically more complicated, were also excluded, and patients who were lost to follow-up. So our study group was divided into open surgery and laparoscopic surgery, and intraoperative and postoperative morbidity indicators, and progression-free and overall survivals were noted for both groups. I won't go into much detail about the statistical analysis. It was done using the SPSS software version 27. So patient characteristics, the mean age was 52 years. Mean BMI was 25.9. And more than half of our patients, which is 56.1%, had an ECOG performance status of 0, which means that they were generally healthy. If we look at the p-values, none of these results, the differences are statistically significant, which means that both these groups were comparable when it came to age, BMI, and ECOG performance status. The most common histology was high-grade serous ovarian cancer, which is the most common occurring ovarian cancer type. If we look at the short-term post-operative outcomes, we looked at estimated blood loss, blood transfusion, the need for blood transfusion, hospital stay, need for ICU admission, the number of neoadjuvant chemotherapy cycles, so the number of chemotherapy cycles that the patients received before surgery, length of surgery, and post-operative fever. And the red arrows next to 4 of these results are statistically significant results, which means that estimated blood loss, the need for blood transfusion, number of neoadjuvant chemotherapy cycles, and length of surgery were all significant findings. And most of them were in favor of laparoscopic surgery except length of surgery, which is more for laparoscopic surgery. This was an expected result as we're a training institution and laparoscopic surgery usually takes longer. If we look at the number of chemotherapy cycles, there was an interesting result that patients who received an extra cycle of chemotherapy were more likely to undergo laparoscopic surgery compared to open surgery. If we look at survival outcomes between open and laparoscopic surgery, overall survival and recurrence-free survival were comparable. Like we can see in the Kaplan-Meier curves which are intersecting each other, which means that there was no difference in survival in both groups. So if we look back at a few studies, the first one at the top is laparoscopy versus laparotomy for advanced stage ovarian cancer. This is a systematic review of several previous trials, several previous studies that did not find any survival benefit between laparoscopy versus laparotomy. If we look at the study at the left, bottom left, this is an overview of the current debate between using minimally invasive surgery versus laparotomy for interval cytoreductive surgery in epithelial ovarian cancer. This was conducted by Dr. Dennis Chi, who works at Memorial Sloan Kettering Cancer Center in New York. He is a proponent of open surgery, and he concluded that we need more studies to definitively conclude whether laparoscopy is equal or superior to laparotomy when it comes to ovarian cancer. And if we look at the third study, which is on the bottom right, laparoscopic versus open debulking surgery for advanced stage ovarian cancer, this is a 10-year data analysis similar to our study, and they also concluded that there is no difference between the two surgical techniques. So our conclusion was that laparoscopy does offer short-term benefit in terms of intra and post-operative indicators, but there was no significant survival benefit that was noted in one group over the other. There's an ongoing phase 3 non-inferiority trial called the LANCE trial, and it's recruiting patients currently. So we will have a definitive answer to this question soon. Thank you.
Our next speaker is, we have a very interesting topic being presented by Dr. Maria Habib. Dr. Maria Habib is Fellow of Gynae Oncology at Shaukat Khana Memorial Hospital, Lahore. She will be enlightening us on evaluation of complete gross cytoreduction in advanced stage epithelial ovarian cancer according to European Society of Gynecological Oncology quality indicators. Dr. Maria, please come to stage and deliver your talk.
I am here to present my audit that I have recently conducted on ovarian malignancies. It is very important to know whether we are doing complete cytoreductive surgeries or not, because they are going to affect progression-free and overall survival of our patients. As we all know that ovarian cancer, that is the most lethal gynecological malignancy with overall 5-year survival of 50%, and we know that with each advanced stage, the survival decreases. The primary debulking surgery, that is the main treatment strategy in ovarian cancers, followed by platinum-based chemotherapy. But as I mentioned that I'm going to present advanced stage ovarian cancers. So there are two options in these patients. Either we can go for the primary debulking surgery, or we can go for the neoadjuvant chemotherapy, followed by debulking surgery and then chemotherapy regimes after that. So the gynae oncology group defines optimal cytoreduction as residual disease that is less than 1 centimeter in maximum tumor diameter, complete cytoreduction as no gross visible disease, and suboptimal cytoreduction as residual tumor of more than 1 centimeter. So the greatest survival benefit is seen in patients who achieve removal of all macroscopic disease. So to achieve complete cytoreduction, it includes additional procedures and complex surgeries, including peritoneal resections, bowel resection, and supradiaphragmatic procedures. So all of these procedures are associated with higher intraoperative and postoperative morbidity. It is very important to assess whether complete cytoreductive surgeries are being performed in cases of advanced ovarian cancers, as incomplete cytoreductive surgeries, as I mentioned, that they lead to poor progression-free and overall survival. So what are the standards that we have to follow? These are the European Society of Gynecological Oncology quality indicators that tell us that for complete cytoreduction should be achieved in more than 65% of the cases, and the minimal target should be more than 50%. So this audit was conducted in the gynecological section of Surgical Oncology, Shaukat Khana Memorial Cancer Hospital and Research Center, Lahore, and approval was taken from the Quality and Patient Safety Department. It was a retrospective cohort data, and the duration was of 3 years from January 2021 to December 2023. All the patients that were treated for advanced stage epithelial ovarian cancers, they were identified from the pathological database, and they were included in the audit. Out of 218 patients with advanced stage epithelial ovarian cancers, 127 patients were included in the study, as those patients were excluded who didn't have any follow-up data or who were not treated at Shaukat Khana. So here we can see that majority of the patients belong to the age group of more than 50. As I included all the ovarian cancers, including epithelial, germ cell, and yolk sac tumors. So as we know that the most common malignancy is epithelial ovarian cancer, so majority of the patients belong to this age group. But definitely we see patients in younger age groups that present to us with epithelial ovarian cancers. Here we can see that 15.7% of the patients were between the age of 18 to 30 as well. Regarding stage of the disease, the most common stage of the disease that we encounter in our hospital is stage 3 cancers. It is mentioned that 64.6% of the patients had stage 3 cancers, 3C cancers, which means that there was macroscopic disease in the abdomen as well. Okay, so there is some problem with this slide. So this slide is basically showing that that light green portion, that is showing that the major bulk of the patients belong to the epithelial ovarian cancers, and that was of 72% of the patients. Rest of the patients were yolk sac tumors and germ cell tumors. 72% of the patients received neoadjuvant chemotherapy, and 28% of the patients didn't receive neoadjuvant chemotherapy. The reason being that the patients, when they present to us with the adnexal masses, we go for the primary debulking surgery. At that time, we don't have that diagnosis. Otherwise, for stage 3 and 4 disease, it is preferred that neoadjuvant chemotherapy should be given first. And here we can see that primary debulking surgery that has been performed in 43% of the patients, and 57% of the patients underwent secondary debulking surgery. 37% of the patients had laparoscopic surgeries. In Shaukat Khana, we perform laparoscopic surgery in more than 90% of the patients, but because of the tumor bulk and large adnexal masses, we have to undergo open procedures for these patients. Or even if we perform initial staging laparoscopy, then we do laparoscopic assisted surgeries to remove the adnexal masses. Also, I would like to mention that the type of surgery that has been performed included fertility sparing and non-fertility sparing surgeries. In young patients, we prefer fertility sparing surgeries, and those who have completed their families, non-fertility sparing surgeries have been done. Additional procedures that have been performed included peritonectomy in 10 patients, liver or spleen resection in 5 patients, and bowel resection in 17% of the patients. Now, this is the slide that is showing that what is the result of our audit. So 76.4% of the patients achieved complete cytoreduction in our hospital, and suboptimal debulking surgery was performed in 23.6% of the patients. So according to the European Oncology Group standards, our hospital is fulfilling that criteria. In fact, it is going beyond that criteria. So what are the sites of the residual disease in which we couldn't perform a complete cytoreduction? These included small bowel, large bowel, mesentery of the small bowel, diaphragm, pelvic and abdominal peritoneum. Though we have performed pelvic peritonectomy in patients who present to us with advanced disease, but when the disease is very widespread, then it may not be possible to achieve complete peritonectomy. And in 6% of the patients, there was a widespread disease in the omentoperitoneum, and in 6 patients, there were disease on the multiple sites. Okay, fine. Okay, so I'm sorry, my presentation is not showing any percentages here, but I can tell briefly that majority of the patients that present to us, they have a very good follow-up data, and there are very few patients, around 5% of the patients who were lost to follow-up. So majority of the patients, they were in remission, and around 42% of the patients, they were having relapse, and out of those 42% of the patients, 12 patients died during a median follow-up of 36 months. So an extensive surgical effort with systematic removal of peritoneum and implementation of upper abdominal procedures lead to significant increase in complete cytoreduction. So this is a study that is showing that a paradigm shift in advanced ovarian cancers outcomes of extensive primary cytoreductive surgery. Basically, this study has shown that is there any high perioperative morbidity and mortality of these patients who undergo complete cytoreductive surgeries or not. So this study has shown that non-significant results they have found when the patient undergo advanced laparoscopic surgeries and complete cytoreductive surgeries. This study is showing that whether systemic lymphadenectomy has any role in patients who undergo secondary cytoreductive surgery. So systematic lymphadenectomy has no major effect on progression-free or overall survival in patients who undergo secondary cytoreductive surgery. And with the passage of time, laparoscopic surgical techniques have evolved, and with the improvement of technology and intraoperative and perioperative care, so we can undergo these advanced surgical procedures. And it is very important to have multidisciplinary team meeting before going for such kind of surgeries, because it really changes the management plan of the patients. Thank you so much.
We have a talk on efficacy and safety of plasma gel as an adjuvant to cytoreduction surgery in advanced stage ovarian cancer, a meta-analysis and systematic review by Dr. Anusha Ashkar. Dr. Anusha is a graduate of Dow Medical College. Dr. Anusha, would you please join us on stage for your talk?
Thank you once again for giving me an opportunity to present my research. So before I begin, I would just like to say, what was the reason behind doing this research? For that, I just want to say that the epitome of being a doctor is to be an empath and have a burning desire to reduce the pain of the ailing. And at the level of my career, at which I am right now, this is the best I could come up with. So the title of my research is Efficacy and Safety of Plasma Jet as an Adjuvant to Cytoreductive Surgery in Advanced Stage Ovarian Cancer. It's the first meta-analysis of its kind in the world right now. So let's begin with it. So before we move further, I would like to say about cytoreductive surgery. Basically what happens is that when primary debulking surgery cannot be done in advanced stage ovarian cancer, cytoreductive surgery is being carried out. And as my speaker, she said it clearly that cytoreductive surgery consists of interval debulking surgery as well as neoadjuvant chemotherapy. So instead of the conventional methods that are being used like electrocautery and diathermy, now plasma jet is now introduced to be an adjunct in cytoreductive surgery. So let's move further. So this is the background. The research was conducted to assess the therapeutic efficacy and safety of plasmajet. Since ovarian cancer is a debilitating disease affecting millions of people, millions of women worldwide, with thousands of deaths, and the number is being anticipated to increase to up to 50% by the end of 2040. So that is quite a staggering number. So let's move further. I'll keep it short. Now, what we did in this meta-analysis, we used the databases. 3 databases were being used, and the search string was being used as follows. The statistical analysis was being carried out by using the review manager 5.4, and random effect models are being applied with the inverse variance in place. So both quantitative and qualitative analysis, both were being performed. So the results of a quantitative analysis, while including 4 studies with approximately 400 patients, and 250 undergoing CRS with plasmajet, it showed that sorry for the typo, it's basically complete macroscopic cytoreduction. So complete macroscopic cytoreduction was being achieved in 70% of the patients who underwent cytoreductive surgery with the plasmajet. Along with that, blood transfusion requirement was just 27%. Although the occurrence of urinary tract infection was 10%, but the superficial wound infection was 3%, the occurrence of pneumonia was 2%, and anastomotic leakage was reported in 1% of the patients who were being included in a meta-analysis. So going on for the qualitative results, this was the crux of a qualitative results. It was being analyzed, and it was said that intraoperative blood loss was lower for the plasmajet as compared to the conventional methods, that includes diathermy and electrocautery. Then the operative time, however, remained much higher for plasmajet, but the duration of hospitalization was quite less, so it kind of balances the efficacy of plasmajet over the conventional methods. And the good thing is the mortality was being lower for plasmajet. The patient-reported outcomes were lower for plasmajet, the negative patient-reported outcomes are low for plasmajet. So this kind of concludes my research. It says that more studies are being needed to further strengthen our hypothesis and our conclusions, and we really hope that a day comes when we do not have any cases of ovarian cancer. So thank you so much.
Coming up next, we have a Dr. Musarrat Hassan, who will enlighten us with experience on ultrasound-guided aspiration of cystic pelvic mass, a review of 417 cases. I invite Dr. Musarrat to deliver her talk.
All right, Bismillah ar-Rahman ar-Rahim, in the name of Allah, the gracious, the most merciful. Chair on the dais, Professor Rashid Latif Saab is sitting here. Thank you very much, sir, and all the delegates. So, today, I'm going to talk about ultrasound-guided aspiration, review of 417 cases. My co-author is my own daughter, Fatma Musarrat. She is now in UK, but we worked together for a long time. Based on ultrasound criteria, diagnosis of cysts, abscess, endometriomas, pelvic collections were made. Therapeutic versus diagnostic aspirations were carried out. Masses were aspirated perabdominally by freehand technique, whereas endovaginal route was applied for those masses which were small, and 14 to 18 gauge needle were used. And based on the viscosity, that needle was chosen for aspiration. All patients were reassessed after 15 days to evaluate any pain, discomfort, spill, or recurrence. After meeting the selection criteria, 417 cases of pelvic masses were aspirated. As you all know that this is a chocolate cyst, classical ground glass appearance. So we aspirated it, and you can see the mass is reduced. And this is the freehand technique which we are using. If you want to know in the question-answer session, we can explain that as well. This is another patient where you can see echoes on the left side looking like chocolate cyst. This is the tip of the needle. And we aspirated this mass, but this was not chocolate cyst as it looks like. It was an ovarian abscess. So be careful when you're treating because you don't know what is inside. And this is what we took out from that, what we first thought was a chocolate cyst. We have this patient where we see clear fluid. It looks like no internal echoes. The needle is seen within the mass. The tip of the needle is always visualized. And we thought it was a clear fluid, but it turned out to be with a reddish tinge, and that's what was it. And this is the amount of fluid taken out. Here we have another patient. Side by side, you can see the uterus, the fluid, and that's a needle. And we said it is a clear fluid. And yes, it was clear fluid. And there was no internal echoes in that as well. This patient looks like a cyst, no internal echoes, looks like a normal cyst, simple cyst. But to our surprise, when we put the needle, it was chocolate cyst. So take-home message, we are going to talk in the end. And this is the patient which we aspirated 5,000 cc of fluid in one go. And this is the amount. This is the patient where you can see absolutely clear fluid, no internal echoes, the needle is in place. When we aspirated, it turned out to be dark yellow color fluid. And all those fluid we take out, we send them for analysis. Looks like chocolate cyst from every aspect. Even I thought this is a chocolate cyst. I wrote it as a chocolate cyst. And then when we aspirated, this is the uterus and the mass. To our surprise, it turned out to be a tuberculous collection of green color. It was not endometrioma. It was not a simple cyst. So these are the surprises which we get over a period of time when we aspirate them. This is an endovaginal scan which you can see. We use a puncture adapter and we put the needle. You can see the needle going with the puncture adapter. Very simple, very quick procedure. We always use color for that because in color you get two information. You see the needle and if the fluid is coming out or not, because you constantly see the color when it is coming out. And when we are reducing it, you can see the mass is reduced. And the drained fluid was through the endovaginal, was yellow colored, so it was looking absolutely clear fluid on ultrasound. This is the patient referred by a gynecologist who knew that this is an endometrioma, endometriotic cyst, bilateral. So we did the ultrasound. We also thought, yes, internal echoes, very good through transmission, and we thought it was a chocolate cyst, and that's the other view of this. But when we drained, it turned out to be a yellow color fluid. This is the surprise which we are getting when we are aspirating. Now the tricks of the trade, one must know when doing ultrasound. This is the urinary bladder, uterus, and the mass. Mass looks absolutely cystic, but there is a trick, and the trick is always increase the gain, which does not fill up echoes in the urinary bladder, but fill up echoes in the mass, then is chocolate cyst. This is the large mass which was reported as a ovarian cyst. Please aspirate it. Before we could aspirate, we did the lumbar region, we did do the flanks ultrasound also to see the kidneys in every patient. And this dipping sign told me that, this is not a cyst, ovarian cyst. This is a large hydronephrotic kidney which was seen in the lumbar region as well in the pelvis. Well, this is an unmarried girl, so you can see it looks like a chocolate cyst. And we see the long axis, we don't see vagina, so we say it is hematometrocolpus. That's simple. Unmarried, there is another trick. This looks like internal echoes, but not very clear. We did long axis, we do see internal echoes. We do the labial scan, and this is the labial scan. And for labial scan, there are certain tricks, if you want to ask me later on, that how do we get these images. And we know that this is a chocolate cyst. This is the patient who was an elderly patient and was not fit for operation, was diagnosed as cancer of the ovary. and not fit for anesthesia. So I asked the gynecologist that, can I aspirate, relieve her pain at least? She's already dying. So we aspirated 12,000 cc of fluid from this mass in 6 sittings. That means 2,000 every week. And when we aspirated it, she came first time on a stretcher. And she went walking when we did the last scan. So this is the mass which by ultrasound looks that there is some growth at the back. These are echoes. This is a image of panoramic view, those are you aware of. Now this is the patient which was diagnosed as chocolate cyst by the ultrasound expert. And we always do lumbar region in every patient. We do color Doppler in every patient. So what we did was, when we did long axis, we realized that the kidney's lower pole is elevated, and this was actually sauce abscess and not a chocolate cyst. So these are the surprises which we get. Now, whenever we do the ultrasound, we also do power Doppler, we do SMI, and we see the comet tail artifacts from these. If it is, it's an infected ovarian cyst. We can do the whole lecture on that. So in conclusion, I would say masses below 5 centimeters in diameter and behind the uterus should be aspirated by vaginal route. Masses above 7 mean diameter should be aspirated by abdominal route using freehand technique. It's so simple that with some training you can do it every day. Masses which overlaps in diagnosis should be aspirated. We say diagnostic and then convert it into therapeutic. In unmarried and those not fit for operation, aspiration should be done. We all know the reason, because they have to get married, acha pehle surgery kahan karai thi, kya hua tha, and so on and so forth. In fertility stage of life, aspiration and ultrasound guidance should be done to avoid adhesions. And I found no adhesions after the puncture of the needle. It's not even laparoscopy, it is just putting the needle. Gauge and length of the needle should be decided on enhancement or attenuation of the fluid, of the sound vibrations. Color Doppler should always be done to avoid any blood vessel in between. Large masses are always advised to be aspirated to reduce the size to avoid decompression. Repeated aspiration can be done in some cases which results in no adhesions. Ultrasound-guided aspiration of pelvic masses is relatively safe, simple, and cost-effective alternative to more invasive methods such as laparoscopy and laparotomy. Thank you very much.
First talk on CA endometrium is by Brigadier Vicar Ashraf. Brigadier Vicar Ashraf is HOD of OBGY in Army Medical College and Pak Emirates Military Hospital. Madam will give talk on very interesting topic, correlation of ultrasound and histopathology for diagnosis of endometrial cancer in postmenopausal women. Madam, please come to stage for your talk.
Good afternoon, respected Sir Rashid Latif Khan and respected Chair and dear delegates. I know it's very difficult putting up in the late afternoon session. Thank you for bearing with us. As a gynecologist working in the largest military hospital, that is the Pak Emirates Military Hospital, I am privileged to present my research work on the correlation of endometrial thickness measured with transvaginal ultrasonography and histopathological diagnosis of endometrial cancer in postmenopausal women presenting with abnormal uterine bleeding. I would like to take this opportunity to express my gratitude to Professor Nazli Hamid and her team of organizers who have done so well to bring this summit together and working towards the development of subspecialties in gynae-ops. This is the place I call home, the Pak Emirates Military Hospital, where we work tirelessly for patient care and innovation. Endometrial cancer is the 6th most common cancer in women the world over. Every year, 400,000 new cases are coming up, and there is increasing incidence in morbidity and mortality as well. In Pakistan especially, it has been estimated, according to one study, that the incidence is 7.4 per 100,000 women, and one of the studies it has also been said it is 8.4%. Globally, we see that China, United States, and Russia are the leading countries in this respect in the incidence of endometrial cancers. There isn't a universally accepted screening tool for endometrial cancer. Transvaginal scan is the preferred method of investigation as it is non-invasive and has excellent sensitivity. The other things that we use are included in the armamentarium are the MRIs, hysteroscopies, and endometrial biopsy is used for a definitive diagnosis. The rationale of our study is that the early detection of endometrial cancer, it improves survival, decreases morbidity and mortality. The current methods which are usually available are biopsies, DNCs, which are invasive as well as expensive. Abnormal uterine bleeding, whenever it comes to Pak Emirates Military Hospital, we receive a large number of patients every year in the postmenopausal age group, and our standard of practice is that we perform ultrasonography in the form of transvaginal scans to assess the uterine lining and uterine structures. The rationale of our study is to correlate the sonographic findings by transvaginal scan with histopathology for the diagnosis of endometrial cancer in postmenopausal women presenting with abnormal uterine bleeding. It is a quasi-experimental study, and it was carried out between July 23 to June 24. We included all postmenopausal women who presented with abnormal uterine bleeding and excluded women with adenomyosis, fibroids, polyps, blood dyscrasias, or who were using any blood thinning agents. A non-probability consecutive sampling technique was used. Proper history taking and examination was performed, and patients were randomized into two groups. The demographic characteristics were recorded for all patients in the form of age, parity, their menopausal status, weight, BMI, presence or absence of comorbids. The patients who fulfilled the inclusion criteria were randomized subjected to transvaginal scan. Sample was randomized according to the endometrial thickness. The group A included the abnormal thickness with an endometrial thickness more than 5 millimeters. And group B was the group which was with normal endometrial thickness, which was less than 5 millimeters of mercury. All the patients were scheduled for endometrial biopsy, and the biopsy sample was sent for histopathological review. The histopathology report by a consultant histopathologist with an indication of endometrial cancer was considered a positive report. The primary outcome was sensitivity, specificity, positive predictive value, and the negative predictive value of sonography in screening for endometrial cancer. The frequency of positive histopath was also calculated as a secondary outcome. The data was analyzed on Social Sciences SPSS 26. I will not go into the details. This is the study protocol that we used. The results, the frequency of endometrial cancer in histopath was 23% in group A, where the abnormal endometrial thickness was recorded, and it was only 2 in those who had a normal thickness. There have been a few studies performed to correlate the sonographic findings to histopathology, but most of these studies are retrospective and systematic reviews. We have performed a prospective study, and we have used the demographic characters of patients with a similar background. These were our results. The abnormal transvaginal scan thickness group came out to be 23%, 23 patients who had a positive report on histopathology out of 64. The group B, only 2 patients had a positive report on histopathology. So the positive predictive value of ultrasonography came out to be 58.6 and sensitivity of 64.1%, and it was negative predictive for 79.8% of patients. The limitations of our study were that it was a single center study. We did not receive any funding, and we have no conflict of interest to declare. A little bit about the literature review. So far, there have been studies carried out. There is a local study by Mohammed Kaleem et al., and they said that they performed a systematic analysis of 6 articles, and they said the endometrial thickness correlates well with histopathological diagnosis of endometrial cancers. The strength of our study is that we performed a prospective studies and we performed comparisons between 2 groups. We also performed, there is another study which was performed by Shalini Malhotra. They concluded that increased endometrial thickness can also correlate well with the histopathological diagnosis of endometrial cancer. But they performed hysteroscopic guided biopsies. We have not performed hysteroscopic guided biopsies. We performed DNCs and papal biopsies for the diagnosis of endometrial cancer. In those patients who had a normal endometrial thickness but had postmenopausal bleeding, in those patients, in order to remove the negative bias, we did perform DNCs to curate all the endometrium. So, going back, we concluded from our study that we can use in a resource-poor country like Pakistan, we can safely use transvaginal scan for screening tool to pick up abnormal endometrial thickness and diagnose endometrial cancers. These are the references that I've used for my study. And thank you very much for patient listening.
Our next talk in the endometrial cancer series is Role of Lymphadenectomy in Management of Early Stage Endometrial Cancer. We have one of our previous speakers joining us again, Dr. Khayal Azam Khalil, Fellow of Gynae Oncology at Shaukat Khana Memorial Hospital. Please, Dr. Khayal, come to stage for your talk.
I will be talking about the role of lymphadenectomy in the management of early stage endometrial cancer. I don't have any conflicts of interest to declare. Endometrial cancer is one of the most commonly occurring gynecological cancer. This has been reiterated before me by 2 other speakers as well. The need and type of adjuvant therapy in early stage endometrial cancer is reliant on the histopathological spread of the disease, which is usually established post-surgery. So surgical staging has a very important role in the management of endometrial cancer. Lately, sentinel lymph node mapping has become the standard of care to guide pelvic lymph node dissection, which is not being carried out at our hospital. The objective was to determine the role of pelvic lymphadenectomy by assessing nodal positivity on progression-free and overall survival in early stage endometrial cancer. This is a retrospective cross-sectional study conducted from January 2019 to December 2023 at the Department of Surgical Oncology at Shaukat Khana Hospital in Lahore. So we took patients with early stage endometrial cancer, which is stage 1 and stage 2 disease, assessed nodal positivity of the disease on histopathology, and looked at whether they received adjuvant treatment and the first evidence of recurrence. Talking more about the inclusion criteria, 89 women were found to fulfill the inclusion criteria, which was early stage endometrial cancer. The exclusion criteria was women with endometrial cancer who did not undergo pelvic lymphadenectomy, or they had no histopathological evidence of lymph node tissue on the submitted specimen. So essentially, they did not undergo pelvic lymphadenectomy. Women with advanced stage ovarian cancer, which is stage 3 and stage 4 disease, patients with a poor ECOG performance status, which means that they had other comorbidities that affected their survival outcomes. Patients who were morbidly obese, BMI of more than 40. Women who were lost to follow-up or had more than one primary cancer. This also affected their prognosis, so they were excluded from our study. Patients who had incomplete adjuvant therapy data or who contracted COVID-19 during treatment were also excluded. Statistical analysis was done using the SPSS software version 25. The mean age was 54.7 and BMI was 32.2. We looked at the type of surgery, whether they underwent open or laparoscopic surgeries, whether there was any radiological evidence of lymphadenopathy before the surgery, whether they received adjuvant chemotherapy or adjuvant radiation after the surgery, and whether they had any lymph node positivity. I would like to recall that this is early stage endometrial cancer where we do not expect lymph nodes to be positive. But we found that 6.7% patients had positive lymph nodes on histopathology. The most common histology was endometrioid adenocarcinoma, which is the most commonly occurring endometrial cancer. These are the overall and progression-free survivals, which are usually good for early stage endometrial cancer. So the most salient results were that only 2 patients underwent para-aortic lymphadenectomy in addition to the pelvic lymph node dissection. So routine systemic lymphadenectomy only included bilateral pelvic lymph node dissection. So para-aortic lymph nodes were not always assessed. 17 patients had lymphadenopathy on radiology scans. So these patients had evidence of lymphadenopathy on radiology before surgery. 6 patients were found to have nodal positive disease, out of which only 3 had lymphadenopathy on scans. So only 3 patients out of the 6 who had positive nodes had any indication that they might have advanced disease. 26 patients who had cytological evaluation of peritoneal fluid, which was done at the discretion of the operating surgeon, only 4 were positive for malignant cells. Amongst the patients with lymph node positive disease, 1 was found to have disease recurrence despite adjuvant treatment. So we concluded that patients who underwent pelvic lymphadenectomy and were subsequently found to have nodal disease and went on to receive adequate adjuvant therapy, some of them there was no specific preoperative indicator to prompt the decision of pelvic lymphadenectomy. So on presentation, patients who presented with their history and radiology and histopathology that they probably had early stage endometrial cancer, some of them did not have any indication that they would have positive lymph nodes. So one of the previous studies which I would like to mention here was that mentioned selective anatomically based lymph node sampling can replace site-specific pelvic lymphadenectomy in endometrial cancer in case of a failed sentinel lymph node mapping. So this study found that the most common sites of pelvic lymph node metastasis in early stage endometrial cancer was obturator fossa, interiliac area, and the parauterine lymphoid tissue. So instead of doing a full pelvic lymphadenectomy, these 3 areas can be anatomically selected for the most common sites of metastasis. Another study looked at the prevalence and size of pelvic sentinel lymph node metastasis in endometrial cancer. 12.7% women with preoperatively presumed low-grade endometrial cancer had metastatic sentinel lymph nodes. The proportion of a small volume of sentinel lymph node metastasis is related to endometrial cancer histological risk profile that we know from the new endometrial cancer staging, which is still under debate. And detection of sentinel lymph nodes should be performed in all women with endometrial cancer. Another study which was previously done is lymphadenectomy for high-grade endometrial cancer and whether it impacts lymph node recurrence. Positive lymph nodes at surgical staging predict nodal recurrence. Recurrence-free survival is longer in patients with positive lymph nodes where a more extensive lymph node dissection is performed, and surgical debulking of positive lymph node in high-risk endometrial cancer may have an oncological role. So with the conclusion of our study, we considered that incorporation of sentinel lymph node technique at our institution which is ideally done with the ICG dye, but since that's not available, other alternatives like methylene blue dye can be considered. Thank you.
Now we have another fellow of gynae oncology at Shaukat Khana Memorial Hospital rejoining us. The time she will educate us on laparoscopic assisted posterior pelvic examination in a case of uterine carcinosarcoma, a video presentation. Dr. Maria Habib, we welcome you back on stage.
Assalamu alaikum. So I am here to present a video of laparoscopic posterior pelvic exenteration in a case of uterine carcinosarcoma. Basically, pelvic exenteration that is considered to be a mutilating procedure that is now in practice because of the advanced surgical technique and perioperative care. So this procedure that was previously considered to be a mutilating procedure, it is now considered to be a curative one. So in cases of advanced disease, we have to go for the bowel resections and pelvic exenterations as well, because it increases the progression-free and overall survival of the patients. So I would be presenting a case of 51 years old lady who was a treated case of breast cancer, presented with the history of vaginal bleed. Endometrial biopsy outside hospital showed carcinosarcoma. So she was basically referred to Shaukat Khana for further management. Her imaging revealed endometrial thickening with the bilateral pelvic lymph adenopathy, and the case was discussed in multidisciplinary team meeting, and surgical procedure was planned for her, which included total abdominal hysterectomy with bilateral pelvic lymph node dissection and maximum disease debulking. The important thing that I would like to mention is that this patient was opened in some outside hospital, and then she was referred here because they considered this disease to be an irresectable one because there were dense pelvic adhesions in the pelvis. So the consent of bowel resection was taken before going for this procedure. So after initial staging laparoscopy, here we can see that there were dense adhesions of the uterus with the rectum, and the disease seemed to be involving the rectum and superficial parts of the uterus as well. So the plan was to undergo her pelvic exenteration. So after skeletonizing the infundibulopelvic ligament, bilaterally they were clipped and ligated. After that, the uterus was mobilized from the rectum. Then medial to lateral mobilization of the sigmoid colon was done. It is very important to take care of few important structures like right ureter and hypogastric plexus, because it lies just below this part of the procedure. So we have to clip the inferior mesenteric pedicle here. The mobilization of the upper rectum was done. This extensive mobilization helped us to remove the disease and block and to go beyond the tumor margins. After that, lateral to medial mobilization of the sigmoid colon was done. After that, inferior mesenteric pedicle was skeletonized, clipped, and ligated. After that, uterine pedicles were taken bilaterally, they were clipped, ligated. And then cervix was prepared for colpotomy. And then colpotomy was performed. And intracorporeal suturing of the vaginal vault was done. After that, the rectum was prepared for transection. Transection using echelon 60 mm green staple was used. After that, because carcinosarcoma, that is the aggressive histopathology, so we have to go for the systematic pelvic lymph node dissection as well. So here we can see that these are the external iliac vessels and lymph nodes were taken from that area. And here we can see left obturator nerve. That is the inferior limit of the pelvic lymph node dissection. So we have to take all the lymph nodes from the external, internal iliac and obturator fossa as well, while taking care of the ureter here. So that is the final picture of pelvic lymph node dissection. Here you can see the external iliac arteries, veins, obturator nerves, internal iliac arteries, and ureters. After that, endobag was inserted to remove the pelvic lymph node dissection specimen. After that, phenestrel incision was given and uterus with bilateral tubes and ovaries along with sigmoid colon was retrieved, because that is the main objective of pelvic lymph node, pelvic exenteration, that we have to remove the specimen en bloc. After that, proximal colon transection done, and anvil was inserted and again placed in the abdominal cavity, circular stapler inserted via the rectum, because now we have to do the colorectal anastomosis. Here we can see the part of the rectum that is prepared for the anastomosis now. After that, the suture line was reinforced with Prolene suture, as it decreases the chances of leak at anastomotic site. And then omentectomy was performed. So the patient was discharged on 5th post-operative day, and the histopathology was consistent with our initial diagnosis, that was carcinosarcoma. But the interesting finding was that was a stage 1A disease, and the margins were negative. All the lymph nodes were free of tumor. So that was a very good thing for the patient that she underwent this surgery, because if she wouldn't have underwent surgery, then the tumor could have taken her life. Thank you so much.
Our next talk is on comparison of staging by MRI and histopathology in women with endometrial cancer by Professor Zartaj Hayat. Professor Zartaj Hayat is HOD of Gynae Unit 2 in Fauji Foundation Hospital, Islamabad. Dr. Zartaj, please come to stage to deliver your talk.
Bismillahirrahmanirrahim. Esteemed panelists, ladies and gentlemen, Assalamu alaikum and good afternoon. First of all, I want to congratulate Professor Nazli Hamid, who is sitting in the back row. I was thinking she's not here, for conducting such a wonderful and, I must say, successful academic event and giving me an opportunity to be a part of it and share with you a small research which we carried out at our institute at Foundation University, Fauji Foundation Hospital. I'm working in this hospital for the last 2 decades, and we deal with a lot of gynecological oncology in our hospital due to 2 reasons. Firstly, it is a tertiary care referral hospital, and many of the patients from peripheral areas are referred to us. Secondly, the hospital provides health services free of cost to the ex-army servicemen and women we encounter in the age group where we see more of the gynecological oncology. So this is the institute where I work. My layout of today's presentation is that I will be briefly discussing the background. I will just touch it. My other colleagues have already discussed, and then I will be discussing my research. So, as already said, it is the 6th most commonly occurring gynecological cancer. In Pakistan, the overall prevalence is ranging from 5 to 7% per 100,000 population. We generally classify endometrial carcinoma in two ways. First is the histological classification, in which there is endometrioid carcinoma, which is classified as low risk, and non-endometrioid carcinoma, including serous, clear cell, and carcinosarcoma, that we take as high risk. Then the grade of the tumor, grade 1 and 2 are taken as low grade, and grade 3 is taken as high grade. The purpose behind this classification of low risk and high risk group is to plan a better management, because for the low risk group, total abdominal hysterectomy and bilateral salpingoid oophorectomy is all that suffices. However, for the high risk group, extensive surgical approach, including pelvic lymphadenectomy, is the standard of treatment. While looking at the poor prognostic markers and planning the management, apart from the grade and type of the cancer, lymphovascular space invasion, involvement of uterine cirrhosis and cervix, invasion into deep myometrium, positivity of the lymph nodes is also taken into account, and magnetic resonance imaging is used to assess the extent of the disease. In the new era, FIGO in 2023 has incorporated molecular analysis, tumor type, and lymphovascular space invasion in the staging system. However, in the resource-poor setting like ours, we have yet not incorporated this staging system, and we are following the older one. The objective of our study was to compare the staging by MRI and histopathology in women with endometrial carcinoma. The rationale was to assess the validity of magnetic resonance imaging in staging of endometrial cancer and comparing it with the surgical staging of the disease, so that a better pre-operative management plan can be made and extensive surgery would be possible to limit to the high-risk group and can be avoided in the low-risk group. So the aim of our study was threefold. Firstly, we want to assess the diagnostic accuracy of MRI in pre-operative staging of endometrial carcinoma. Secondly, we wanted to see the role of MRI in the local spread of the disease by comparing myometrial and cervical invasion with the histopathology of the surgical specimen. That was our secondary outcome measure. The other secondary outcome measure was to check the predictive value of pre-operative biopsy and MRI in detecting low-risk and high-risk disease. So it was a retrospective cohort study carried out in our department over a period of 4 years from 2020 to 2023. And we checked the record from the computer-based system for a period of 4 years. A total of 40 patients of endometrial cancers we found, and data was analyzed. So out of the 40 patients, we excluded 8 patients because 3 patients were lost to follow-up, and 5 patients, they had stage 4 disease, so they were referred to oncology for radiotherapy. Out of the 32 patients, they were staged from stage 1 to 3C. At the initial presentation, 25 patients had postmenopausal bleeding, while 7 patients have abnormal uterine bleeding. The average age of our study group was 61 years. So the methodology which was used, that initially biopsy was done via hysteroscopic guided biopsy, and the grade of the tumor and type of the cancer was assessed. Then preoperative MRI was done to stage the disease, and both the findings were noted. The patients were divided into 2 groups, the low risk and high risk. The low risk group included grade 1 and 2 endometrioid adenocarcinomas, and on MRI stage 1, while the high risk group was who had grade 3 endometrioid adenocarcinoma, the non-endometrioid carcinomas, that is clear cell serous or carcinosarcomas, and on MRI, the preoperative MRI, in which we find stage 2 and 3. So we checked for diagnostic accuracy of MRI, the sensitivity and specificity of MRI in detecting cervical and myometrial invasion. We also checked for the positive predictive value, negative predictive value, sensitivity and specificity of biopsy alone, MRI alone, and then combined biopsy and MRI. Our results showed that the preoperative biopsy, when we found out the grade of, when we checked for the grade of the tumor, majority of the patients, 69%, they were of grade 1 and 31% were of grade 2. However, there was no patient in our study group who had grade 3. When we checked for the type of endometrial cancer, majority of the patients had endometrioid adenocarcinoma, that is 78%. Then, coming to the diagnostic accuracy of MRI, we found out that MRI has the maximum diagnostic accuracy, that is 93% for stage 2 disease, while for stage 1 it is 75% and stage 3, 78%. If you look at the last bar of this graph, it shows the diagnostic accuracy of MRI in detecting cervical and myometrial invasion. For cervical invasion, it is a bit less. However, for myometrial invasion, it is 78%. Then comparing the sensitivity, specificity, negative predictive value, and positive predictive value of preoperative biopsy alone, MRI alone, and combined together, our results highlighted that MRI has a high sensitivity and negative predictive value for detecting high-risk endometrial cancer. However, when combined with biopsy, the sensitivity and negative predictive value reached almost 100%. So, keeping in mind the current standard of treatment of regional lymphadenectomy for high-risk endometrial cancer, we concluded that MRI has a high negative predictive value and diagnostic accuracy. So initial staging by MRI imaging is useful in ruling out high-risk endometrial cancer. We recommend that a more extensive surgical approach with lymph node dissection should only be reserved for the high-risk groups. However, keeping in view the low positive predictive value of MRI in assessing high-risk endometrial cancer, we propose that other modalities like PET MRI and sentinel lymph node procedures be made use of preoperatively so as to prevent unnecessary extensive surgeries and increasing the patient morbidity, surgery time, and the complication rates. But definitely there are limitations to PET MRI and sentinel lymph nodes of cost and expertise. So thank you very much.
Teaching, as they say, is a noble profession, and those who put their maximum effort to impart knowledge to others deserve all the praise. Ladies and gentlemen, it gives my pleasure to invite on stage third time Dr. Maria Habib. Dr. Maria Habib is a fellow of gynae oncology at Shaukat Khana Memorial Hospital. This time, she will be educating us on oncological outcome of immature ovarian teratoma following primary and secondary surgery, a 15-year report from a cancer center.
Assalamu alaikum. I'm sorry you have to bear with me again. So I'm here to discuss oncological outcomes of immature ovarian teratoma following primary and secondary cytoreductive surgery. So we all know that immature ovarian teratomas, these are the rare malignant germ cell ovarian tumors, and they comprise 1% of all ovarian teratomas. They typically affect the younger population, and fertility-sparing surgery is the main surgical procedure that is carried out in these malignancies. But most of the studies that have been conducted, they are on the younger population groups, including pediatric population and adolescent groups, and in women of all ages, immature ovarian teratoma outcomes have not been studied so far. So the objectives are to review the clinical characteristics and oncological outcomes of immature ovarian teratoma following primary and secondary cytoreductive surgery. So that was a retrospective cohort study that was conducted over the period of 2008 to 2023, that is the 15 years data. That is conducted in the Surgical Oncology Department of Shokathana Memorial Cancer Hospital and Research Center, Lahore. Non-probability conjective sampling technique was used. Inclusion criteria included all women with pathological confirmation of immature ovarian teratomas. Those women whose baseline characteristics or primary treatment details were not available, they were excluded, and also those patients who didn't have any follow-up data were also excluded. So SPSS variant 25 was used for the statistical analysis. Patient demographics and baseline characteristics were summarized using descriptive statistics, and progression-free survival and overall survival was calculated from the time of surgery to the date of recurrence or the date of death. Kaplan-Meier method was used for the survival curves. Here we can see that most of the patients belong to the younger age group, as we all know that. But the interesting finding is that the majority of the patients, 48.6%, belong to the stage 1A disease, but they belong to the higher grade group. So having a higher grade is a bad prognostic factor, and we know that when the patient is having stage grade 3 disease, then the chances of getting chemotherapy increases. So laparotomy was the main surgical procedure that was performed in 91.9% of the cases because of the major bulk of the disease, and fertility sparing surgery that was performed in 73% of the patients. Because of the higher grade of the disease, 73% of the patients received adjuvant chemotherapy, though our study group belonged to the younger population group, but still they had to receive adjuvant chemotherapy because of the higher grade of the disease. Around 30 patients relapsed, and the primary sites of relapse were pelvis, mentoperitoneum, liver, and there were other multiple sites in the abdomen and pelvis. At the time of relapse, surgery was the main treatment that was done, and these patients respond very well to the surgery, and adjuvant chemotherapy or chemotherapy at the time of relapse were given to only those patients who were unresectable on imaging. The good thing about this malignancy is that majority of the patients in our study, around 67.6%, they were in remission at a median follow-up of 24 months. And only 13.5% of the patients had relapse, and 16.2% patients were deceased. Only 2.7% of the patients were lost to follow-up, which shows that we have a very good follow-up data of our patients. This is the progression-free survival. Here we can see that over the period of 36 months, over the median follow-up of 36 months, the progression-free survival is 60%, and that is the overall survival, which is 80% over the period of 36 months. So that is a very good survival of these patients. So fertility sparing surgery have good oncological outcomes in cases of immature ovarian teratoma. With secondary cytoreductive surgery and platinum-based chemotherapy, it is possible to salvage most recurrences. So there is a consensus and controversy in the management of pediatric and adult patients with immature ovarian teratoma. In pediatric populations, usually the oncologists avoid giving chemotherapy, but if the patient is having stage 1C or more disease, then at least 1 to 2 cycles of chemotherapy are recommended. Otherwise, surgery is enough for the primary disease. Thank you so much.
After endometrial cancer, now we are moving towards cervical cancer. We have Dr. Bushra Khan. She is ex-fellow of gynae oncology at Aga Hospital, Karachi. Now she is assistant professor at Ayub Teaching Hospital, Abbottabad. Her talk is titled, Exploring the Reason Behind the Late Detection of Cervical Cancer in Pakistani Population. Dr. Bushra, please.
Assalamu alaikum. First of all, I would like to thank the organizing committee for giving me a chance to speak on this important occasion. So I would be talking about exploring the reasons behind delay in detection of cervical cancer in Pakistani population. So why I chose this topic to be discussed today is that cervical cancer being a cancer which could be preventable. There are so many techniques available like pap smear, screening methods. Then if it is early detected, treatment is 100% curable in the early stages. But still we are coming across patients who present in advanced stage. So I do not have any conflict of interest. So the background, approximately 1 in 4 of all the cancers in women in developing countries is a gynecological cancer. The cervical cancer, it accounts for over 60% of the gynecological cancer burden in developing countries. Unlike developing countries, in the developed countries, majority of the cases are diagnosed in early stages, allowing for more conservative therapeutic approaches. Now, the purpose of this study was to explore the reasons due to which Pakistani women do not present in the early stage. So it was an exploratory, descriptive, qualitative study, and it was conducted in the Institute of Nuclear Medicine, Oncology and Radiation, Abbottabad, which is one of the atomic energy cancer hospitals in Pakistan. The sampling technique was purposive sampling, and I interviewed 15 patients with advanced cervical disease from March till April 2024. And semi-structured interviews with open-ended questions were used to conduct an in-depth interviews. So we included those patients, of course, who gave consent. Secondly, patients with evidence of advanced disease. Thirdly, now this third point is important, like patients who did not undergo surgery. Because even we came across patients who had advanced disease and they were operated. Like most of the patients, they were going to the gynecologist and they were labeled as having dysfunctional uterine bleeding without an examination, and they were subjected to surgery. And at the time of surgery, it was diagnosed that they had advanced surgery and they ended up with suboptimal surgery. So those patients who underwent surgery, even they were in advanced stage, we didn't include them. Patients' diagnosis not kept confidential. It is very interesting that we came across 2 patients who had advanced stage cervical cancer, and they were being treated for it. They were being given even radiations, but the family told that the diagnosis is confidential. We have not told this lady, please do not ask her any questions. Now this is very, very strange, and that the patients, even they are being treated, but the family, they hide the disease and they hide the diagnosis from them, thinking that it is beneficial for them. Then exclusion criteria, patients who were incidentally diagnosed as a case of advanced surgery, advanced stage carcinoma after surgery, patients who consented not to participate at any point during the interview or afterwards. So the participants were given information with regards to objectives of the study, confidentiality and privacy. A convenient place was selected and 30 to 45 minutes interview was conducted. Analysis was done using a Brand and Clark method. The results. A total of 15 patients were interviewed, and the average age was 46 years. We identified 6 themes with 25 sub-themes with their corresponding sample codes from the data. Now we come to each theme, and we will be discussing it. So the first theme was knowledge about the disease. There was limited awareness of the sub-themes were limited awareness of the cervical cancer causes and symptoms. Ignorance of the seriousness. Most of the patients were thinking that initially that they just had vaginal infection. They didn't know what was the consequences of this cervical cancer if it goes beyond in advanced diseases. Unaware of screening methods. Misconceptions about cervical cancers. So the codes which we came across were unawareness of the risk factors. No patient knew what were the risk factors of this disease, what does copious vaginal discharge meant to them, irregular pervaginal bleeding, postcoital bleeding, multiple partners, pap smear, vaccination, it was not known to them. Now, believes that screening is unnecessary without symptoms. Most of the patients had that because they didn't have symptoms. Why would they have ever been subjected to screening? Misconceptions linking cancer to supernatural causes. Now, this is something which is there in our society, that they think it is because of some jinn, taweez, and things like that, but it is there. These misconceptions are there. Dependence on hearsay, influence of anecdotal stories over medical advice. The second theme was personal behavior. Now this is something which is difficult to maybe treat, or we cannot do much about it, but it is there. Procrastination in seeking care. They do not, they know that it is important, but they just delay it, delay the treatment, delay going to a doctor. Fear of diagnosis. Now this fear of diagnosis is there even, I was just thinking, it is there even with the doctors. Like if we have some minor problem, we are also afraid of initially going to some doctor or getting ourselves tested, even just an HbA1c if we think so, or a mammography. We are afraid of the disease of the diagnosis. But this is something which is, has personal behavior is there. Self-medication practices, non-adherence to medical advice, shyness, stigmatization, and dependent on male members. Most of the patients, they were like, rather I would say out of 15, all the 15 patients, they were dependent on the male members to take them to a doctor, to make their even decisions whether they need a doctor. They had to discuss it for couple of months that there is some problem, we need to go to a doctor, and then finally they did go to see a doctor. So the codes which we retrieved were delaying visits due to minor symptoms, prioritizing other commitments over health, hesitation to schedule follow-ups, anxiety about a cancer diagnosis, avoidance due to fear of treatment, emotional denial of symptoms, seeking advice from a non-medical source, ignoring prescribed diagnostic tests and treatment. Theme 3, socio-cultural attitudes and beliefs. Stigma around cancer, cultural barriers to healthcare, economic and social pressures. So, fear of social rejection, perception of cancer as a death sentence, avoidance of disclosure within the community, prioritizing financial needs over health. And we can go to theme 4, which is financial issue. And theme 5, this is important, I'm just skipping it because we have less time. Unstructured health system, limited access to diagnostic services, fragmented referral pathways, lack of awareness programs, and overburdened health facilities, lack of awareness programs. Most of the programs which are being run, they're usually for the awareness of probably the doctors, because they're conducted within the hospitals and they are not community based. So we have to address the population, the women in the community, to think over it that they need to screen. They have to go to screening centers if there are any. Then theme 6 is lack of commitment of treating physician. Now this is something, most of the patients, they had a lot of papers with them which showed that they were going to some doctors, but they were being treated for infections, simple infections. They were being given multiple antibiotics. Nobody ever did a vaginal examination. And it was when the disease was advanced, that was a point when a vaginal examination was done and the patients were sent for treatment. So we have the recommendations which I think are these. Early detection through a proper health care system with cervical screening programs should be initiated. Preventive measures like vaccination against HPV to teenage girls should be started. Pakistani women are mostly dependent on their male family members, so women need to be empowered. There are a number of myths associated with cancer which needs education and awareness programs. Healthcare system needs to be improved by making policies on government level with the consensus of all the stakeholders to bring awareness, to report early, educate and support women with the disease. Welfare organizations, support programs and zakat need to be mobilized to bear the cost of the diagnosis and treatment. Thank you very much.
The last talk of this session is non-gestational primary hepatic choriocarcinoma in young female, case report of a rare tumor by Dr. Sadia Aftab. Dr. Sadia is HOD of MCH Unit 2, PIMS, Islamabad. I would like to call her on stage.
Assalamu alaikum and a very good evening. I have a very interesting case report here to present, which is very rarely found in the history. But first of all, I would like to apologize in advance for any inconvenience caused by my voice due to the soreness of my throat. So, as the name indicates, the non-gestational choriocarcinoma is a choriocarcinoma. As we already know that the choriocarcinomas, these are rare malignant germ cell tumors. They belong to the spectrum of the gestational trophoblastic diseases. So the non-gestational choriocarcinomas are the choriocarcinomas that are not related to the antecedent pregnancy. They are very rare and they can arise from liver, brain, stomach, pancreas, and gonads. The primary hepatic choriocarcinoma is even rare. Only 11 cases have been reported in males so far in the literature, and 2 cases have been reported in the females. I would like to present the case report of a female. She was 34 years old, para 5. She presented to the gastro department of PIMS with a complaint of right upper quadrant pain for 1 week and PV spotting. When she was being worked up for her right upper quadrant pain, her beta ECG was done in view of her PV spotting, and considering that her LMP was 1.5 months back, then her beta ECG was found to be very high. She was referred to the gynae department for consultation. When this patient was referred to us, she had all para 5, all normal, uneventful pregnancies with no history of any malignancy in the past or in the family. On examination, her liver was enlarged. It was 8 centimeters below the costal margin. She was tender in the right hypochondrial region. Her initial differentials that we made were ectopic pregnancy or pregnancy of unknown location or abdominal pregnancy. Right on the second day of admission with us, she developed cough with hemoptysis, and there was no associated fever. These were the labs. Her HB dropped in the 3 days that she remained with us from 8.2 to 6.9. She had raised CRP. Her LFTs were deranged. Her beta ECG was initially 44,000. After 48 hours, it was 48,000, and after 72 hours, it was 54,000. Her TVS and MRI pelvis, they were all unremarkable. This is her ultrasound abdomen on 16th October 2024, which shows enlarged liver 16.9 centimeter with multiple ill-defined hypoechic areas and indistinct margins with increased vascularity. The TVS, which I already mentioned, this is the MRI picture of the pelvis showing normal uterus and ovaries. This is the CT scan abdomen and chest, which was done on 18th of October. It also showed enlarged liver with hypodense multifocal lesions, mainly in the right lobe, but they were scattered throughout the liver. And it was a highly malignant looking mass with hypervascularity. This is the CT abdomen. Then her CT chest was also done, which showed multiple small nodules in both lungs, cannonball appearance. These are the films of her CT scan chest. Finally, involving the multidisciplinary team approach, her histopathology of the liver lesion was done, which revealed 2 types of cells, cytotrophoblasts and syncytiotrophoblasts, with extensive necrosis and hemorrhages. And immunohistochemistry showed beta ECG positive, SAL4 positive, CKEA positive, and inhibin positive. These are the films of histopathology of the liver malignancy of this patient, which were done from Shifa Hospital, Islamabad. Finally, opting for the multidisciplinary team approach, her chemotherapy, because it was a lesion involving the whole liver, and she had also mets in the lungs, so she was planned for chemotherapy. Only bleomycin, etoposide, and cisplatin, only 1 dose was given, and the patient expired before she was offered the next dose. So coming back to the literature review, as we all know, the choriocarcinoma, it can be gestational and non-gestational. The non-gestational choriocarcinomas, they are not related to the antecedent pregnancy. They can arise from reproductive organs or non-reproductive organs, which is the main focus of this discussion. The non-reproductive organs, as I already mentioned, are liver, intestine, brain, stomach, pancreas, and many other. This is the clinical case series of 13 male patients with primary choriocarcinomas. And this was done in China in 2014. 7 primary sites of choriocarcinomas were identified in males: testes, mediastinum, lung, jejunum, stomach. And these patients were offered with surgical resection followed by chemotherapy. Their 1 and 3 year survival rates were 53% and 43%, but none of them had liver cancer. I have shared here the images of various choriocarcinoma sites like uterine, testicular, gastric choriocarcinoma. Coming back to the primary hepatic choriocarcinoma, it is even rare. It is less than 1% of all the malignancies. Only 2 female cases have been reported so far in the literature. And we are presenting the 3rd case. It has diagnostic difficulties because normally the hepatic choriocarcinoma will present as a lesion in the liver, where most of the people would not go for beta ECG. And secondly, the biopsy, the histopathology, which is diagnostic, it is difficult to perform in view of very vascular lesions of the liver. CT angiography is another important diagnostic tool, which will show a vascular hepatic mass with aneurysmal dilatation. Various treatment options are available in the literature. The first is the surgical resection, like hepatic resection or even removal of the simple lobe of the liver. And then the chemotherapy, BEP or EMACO. There are aromatase inhibitors, which will decrease the level of estrogen and reduce the growth of the tumor. There are anti-angiogenic agents, which will attack on the immune system. They are effective in stimulating the immune system to attack on the tumor cells. Then there are hormonal therapies like GnRH analogs. And finally, the palliative care. Here I have mentioned the case report published in China, which have mentioned the 5 cases of primary choriocarcinoma of liver in males. And in these 5 males, if the tumor was localized, they resected it and offered the chemotherapy. And if it was metastasized, only chemotherapy was offered. But all these 5 male patients died in a period of 2 to 8 months. It is such an aggressive and highly malignant tumor. So the prognosis is generally very poor. The survival time is only 2 to 8 months. The beta ECG levels are used to monitor the progress of the treatment too. This study was published in Korean Journal of Oncology, which shows the first case of primary hepatic choriocarcinoma in a female patient. She was 59 years old. And when she was first assessed, it was thought that it is angiosarcoma. It was only after the hepatic resection that it turned out to be the hepatic choriocarcinoma, and this patient was then offered the chemotherapy. This is the picture of this patient. Because the tumor was localized to the lobe of the liver, so hepatic resection was done. The second case of the female hepatic choriocarcinoma was published again in Korea. It was a primary gravida at 28 weeks of gestation, and she presented with a very vascular lesion in the liver. Initially, it was thought to be hepatocellular carcinoma, and her resection of the liver was done. And only on histopathology it was found to be primary hepatic choriocarcinoma. But this patient was offered termination of pregnancy at 32 weeks, but unfortunately, within 1 month after the termination of pregnancy, she developed metastatic disease and she died. So finally, I would like to conclude that it's a very rare malignancy and it poses great diagnostic and therapeutic challenges. Only early detection, multidisciplinary team approach is required if you want to improve the survival, and further research is required in this area. Thank you.